All right, it's 1 o'clock, so I'd like to welcome everyone who's joined to the Advances in Alzheimer's Research and Care webinar. This is put on through the Society of Nuclear Medicine and Molecular Imaging and is supported by a generous grant from Lilly. My name is Jonathan McConaughey. I'm a radiologist and nuclear medicine physician at the University of Alabama at Birmingham, and I'm part of our imaging core of the Alzheimer's Disease Research Center. We have a great set of panelists to discuss recent innovations in Alzheimer's disease care with a focus on the role of imaging. So I'm going to start by asking Tammy Benzinger from Washington University in St. Louis to introduce herself.
Hi, John. Thanks so much. It's really a pleasure to be here with all of you today on this webinar. My name is Tammy Benziger, and I'm a clinical neuroradiologist at Washington University. I also work really closely with our Alzheimer's Center, the Knight ADRC, where I'm the imaging core leader. And I'm also leading the imaging for our international studies of autosomal dominant Alzheimer's disease, the DIAN and the DIAN Trials Unit. I was also pleased to participate in the recently published joint publication between the Alzheimer's Association and Society for Nuclear Medicine on updated appropriate use criteria for amyloid and tau PET in clinical practice.
Thank you. Next, I'd like to ask Ming-Kai Chen to introduce himself.
Oh, hi. Thanks, John. My name is Ming-Kai Chen. I'm Associate Professor of Radiology at Yale University. I'm also a co-medical director of the Yale PET Center. Yeah, so I've been involving in SNMMI activity for many years. I'm currently actively involved in the Brain Imaging Council. So I'm serving as a president of Brain Imaging Council for this year. Yeah, for those who are interested, if you're interested in the Brain Imaging Council, yeah, feel free to join when you renew your membership. Yeah, that's just one item. You can just select that. Yeah, it's good to be here. Thank you very much.
You're muted, Jonathan.
Sorry, I muted myself. Sorry. Next, I'd like to ask Anna Franceschi from Northwell Health to introduce herself.
Hi, John. Thank you so much for the warm welcome. I'm also very, very happy to be here. So I'm a neuroradiologist at Northwell Health in New York City, where I run the dementia imaging and the brain PET service. So we scan about just over 1,500 brain PETs a year, including over 500 amyloid PETs. And more recently, we were the first institution in New York State to start scanning clinical tau PET and get reimbursed as well. And then in my other roles, I also chair the American College of Radiology Dementia Committee, and I'm the senior editor for molecular imaging for the American Journal of Neuroradiology.
Thank you. And last but not least, I'd like to introduce Howard Phillott, who is from the Alzheimer's Drug Discovery Foundation. And could you introduce yourself, Howard?
Oh, hi, John. Thanks. It's good to be here. I'm a geriatrician by clinical training. I've been taking care of people with Alzheimer's for about 45 years, and a neuroscientist by bench and research training and activity for about the same period of time. And I co-founded the Alzheimer's Drug Discovery Foundation about 26 years ago. And we actually invested in the Amyvid scan, which was the first PET imaging agent to come to market about 20 years ago. So we've been involved in, very interested in biomarkers and particularly PET scans for a long time.
Well, great. Thanks. And we'll get started. I'm going to be moderating and kind of ask some questions, but again, free discussion. If you have follow-up questions, other things that you'd like to bring up, please don't be shy. So we'll start off with an easy question. What are the biggest challenges in Alzheimer's disease research, and particularly how nuclear, in the context of nuclear medicine and imaging? Does anyone want to take that easy one?
Yeah, I could take the easy one.
Okay.
Yeah, I mean, certainly, I think the apparent challenging before the advanced PET scan available is how the appropriate and accurate diagnosis and early diagnosis of Alzheimer's disease. Yeah, luckily, I think with the availability of amyloid PET, I think they'll solve most of the problem that we could potentially detect the amyloid burden as early as 20 years before the clinical presentation. Yeah, I think that's probably that. But certainly, we also need to know there's some challenging that, how the molecular imaging, could help. I mean, how we monitor the disease progression. Yeah, I think certainly molecular imaging also serve an important role that, we could track the disease progression. Before amyloid available, we used to do FDG PET, and I think which could serve that purpose. But amyloid certainly could be very useful to track the disease progression, and also could sort of monitor the therapeutic response with the new available anti-amyloid treatment. So we could see, how the effectiveness of the anti-amyloid treatment. Yeah, with the more recent tau available, I mean, although it may not be all reimbursable, I think tau seem to track the disease progression much better than the amyloid, and also could also assess the severity of the amyloid Alzheimer's disease. So I think I hope tau will be more widely available with reimbursable for that. And then the other is how to be effective assess the treatment response. I think amyloid, and also with the standardized quantification such as the Centiloid scale, I think could serve that purpose. Yeah, and then how to effective distribute those resources. I think that could be one of the challenging to, yeah, but certainly, I think, early and accurate diagnosis is very important. It's challenging, and then how to improve, how to monitor the disease progression and how to assess the treatment response also important, and also how to select the appropriate patient. I mean, certainly amyloid PET could be very useful to identify appropriate patient with amyloid low that we could use the new approved anti-amyloid treatment to target those. Yeah, I don't know if I think Tammy want to add more. I think that's all I can think about.
Yeah, so I can just kind of comment that I agree. I think currently we're very fortunate to have molecular imaging biomarkers for both the A, T, and then the N for the classification of neurodegenerative disease. And in current clinical practice, FDG PET probably still has a very important role in terms of a differential diagnosis of neurodegenerative diseases, especially when we consider the percentage of patients with mixed dementia and co-pathology. And of course, as Min-Kai said, now we have amyloid PET widely available and reimbursed as a core 1 biomarker to allow us early detection of AD pathology in vivo, and slowly, finally, the tau PET, which is emerging, that gives the potential of assessing biological disease severity and potentially performing disease staging. And I think in terms of, next steps for molecular neuroimaging, one side is actually assessing target engagement and treatment response. And I think many of us on this webinar are starting to see that in clinical practice. And then the second side of it is that looking at the Alzheimer's drug development pipeline and the agents that are currently in various phases of clinical trials, there's been a progressive increase in non-amyloid and non-tau targets in that pipeline over the last 5 years. So potentially down the road in a couple of years, we will need other molecular imaging biomarkers to appropriately study, again, target engagement and treatment efficacy as we move towards a multi-pronged approach to dementia therapy.
Excellent.
Yeah, I agree with that. I think we're going to be also moving from a time when we'll be using PET imaging to identify the pathology of the disease to a time, even now, as Hannah mentioned, the last 5 years has really seen a shift towards drug development for the biology of the disease and various pathways like inflammation, for example. So it would be really valuable, for example, to be able to image brain inflammation in patients with Alzheimer's, because we know that contributes to rate of progression and even differential diagnosis. And that's just one example. And I agree also that PET imaging has been critical in drug development. One of the first insights to that came when Lilly bought Avid Radiopharmaceuticals and then studied the clinical trial they were doing with solanezumab, and found out that about 30% of the people in that trial didn't have amyloid in their brain and didn't have Alzheimer's disease. And that was really, I think, a real, very important pivot in Alzheimer's clinical research to be able to actually do much better clinical trials and assure that whether we got positive or negative outcomes on a drug, at least we know the patient population we were trying to target and the target that we were trying to treat. I think another thing that is very underutilized in drug development with PET imaging is phase 0 studies. We've tried to encourage that through our funding. These are relatively inexpensive, maybe 6 to 9 months of chemical modification to fluorinate a small molecule and test it in people for receptor occupancy, target engagement, regional distribution of the target. I've been told that very large pharma actually won't go into a clinical development program without a positive phase 0 study. And I think we really need to take advantage of that. And the other thing I would say is that one of the good things that PET imaging, like for amyloid, has done is help to validate the blood tests that are coming to market now. And ultimately, I think would be doing such a great job with our PET imaging that we're going to put ourselves out of market, out of business, because the blood tests are, what we're seeing in biomarkers and blood tests is just amazing. But they have to be validated on a PET scan, basically, whether it's tau or PET or whatever the target is. And I think that's one of the really valuable things about PET imaging is target validation and showing the value of a blood test, which will ultimately be cheaper and more available and less expensive and more palatable, I guess, to patients. And so I think it's a great new era.
Well, thanks, Howard. Tammy, do you have anything you'd like to add?
Well, just kind of following up on all of this, one of the things that that I worry about a little bit is capacity. Do we have enough capacity to do the amyloid and the tau PET scans that are becoming increasingly requested? And I would love to hear a little bit more from Anna about how you guys are adapting and how do you balance this with the oncology patients that has also had an expansion in nuclear medicine. And then I know most of us on this call have also practiced in diagnostic radiology, and we sort of know from experience what happens when the floodgates open and suddenly, as soon as you have a test that's paid for, it seems like everybody wants it instantly, right? And how can we best sort out who could be better served with amyloid versus tau or both? And I know, as I mentioned, there's this new guideline, but also when someone should get a blood test versus a PET scan, and how can we as specialists help our referring physicians navigate that?
Yeah, I mean, I agree. I think your point, Tammy, that how we integrate, and also Howard, how we integrate blood tests with PET is a big question that I think we'll have better answers for in the next few years. But as you're pointing out, it's a clinical reality now. I think people reading PET are feeling the change.
Yeah, so, at my institution, just looking over the past 4 years, we've increased brain PET volumes tenfold. And just looking at 2023 compared to 2023, the volumes are up 80%. So it's not a process that's really showing signs of slowing down, quite the opposite. And, again, unfortunately, I don't think blood-based biomarkers are there yet, but they're just on the precipice of being clinically relevant. So, in the ideal, I think, dream scenario, they will kind of serve as the floodgates to really triage patients and then need to go on for advanced imaging. Because, to Tammy's point, I think very soon we will run out of, neuro-nukes trained radiologists to read these cases, scanners, technologists, and other resources.
So Anna, do you guys still limit amyloid PET to orders by a neurologist or dementia specialist?
No, we don't. Although, again, the majority of them, the clinical indication is typically like can be candidate. And it's very interesting, though, to see how the results differ based on the referral base. So typically the scans coming from a dementia specialist tend to be positive. I think there's a high probability that they will be positive since the patient has already been appropriately triaged. I also, at the same time, get a number of cases that are coming from outside of the institution, so from community-based physicians. And actually, I think more than 50% of those are negative. And when looking at other findings, you will notice that those are usually patients that are more high elderly, so potentially might have late, either as a primary or a co-pathology, patients that have severe vascular burden. So, probably people that, had they been triaged by specialty clinicians, might have never made it to the amyloid PET. And I think that's a problem that we have to think about how to address as a community as well.
Yeah, I think that's very important that we have the joint effort with the Alzheimer's Association to publish the appropriate use criteria. I think we need to try to disseminate all the critical information to the potential referring or something. They need to know this is appropriate or this is not appropriate just because of subjective cognitive impairment or some kind of genetic risk, and then they've been ordering some of those negative scan. I think eventually, in my opinion, or maybe other opinion, that could be used by the serum biomarker. I think they could be a first cheaper and more available biomarker to screen out those appropriate. Also because there's a pretty good negative predictor value that, if it's negative, then probably no need to do further imaging, and then if it's a positive, then certainly, we could consider taking some of those patients. But certainly appropriate use criteria from SMMI and Alzheimer's Association to be available, and then we need to try to disseminate those information to our referring physician. That would be very useful.
And I think, probably multidisciplinary conferences, something we call ours like a dementia board, and we encourage participation from all stakeholders. So not just radiology and cognitive neurology, but also geriatrics, neuropsychology, the MPPAs employed in neurology. So we're trying to cast a relatively wide net to kind of bring everyone's a knowledge base up to kind of the current standards. But I still see on a weekly basis, questions by neurologists where there is a lot of confusion, and the question is typically, should I send the patient for an FDG, amyloid, or tau PET? So I think people are, while it's wonderful to have all these modalities or all these radiopharmaceuticals currently available in clinical practice, I think a lot of people are confused as to which one is the agent to start with for their patient.
And
go ahead, Tammy.
Well, I was just to say, and coming back around in terms of what we can say that's helpful, Min-Kai, you mentioned the inclusion of the Centiloid. I'm just curious if that's standard for your practice and Anna and John's right now, and if yes or no, why not?
Yeah, I have to confess, I think it's not routinely provided from our service, but we do try to process that, just in case, there's any doubt, like always a gray zone, because we've been doing the binary negative or positive, but, sometimes there's always some gray zone that, I think Centiloid, I think the referring physician will specific ask, what's the Centiloid score, and then certainly we will process that for that, but we don't typically routine report it in our report. But certainly, I know Anna probably reported on a routine base, but but I'd like to hear from her. Yeah.
So, we've been routinely reporting initially SUVRs and Z-scores, and now that the Centiloid workflows by both MIM and Siemens are FDA approved, we also include the Centiloids as well. To Min-Kai's point, I think they're immensely helpful in patients that fall into that gray zone, probably kind of between a Centiloid of 12 and 30, 35. But currently, and then now, and in the near future, as we see scans for monitoring treatment response, I think quantification will become quite indispensable. And probably the strongest argument for employing Centiloid in clinical practice is that all of the decision making in clinical trials, both enrollment and then monitoring therapeutic response, was based on the Centiloid values. So since we do have tools that are FDA approved and available, it's probably best practice in a way to consider including them. Although I know what Tammy is about to say, unlike in Europe, in the US, the FDA label actually for the amyloid PET radio tracers does not include quantification as an option. In fact, it's recommended to provide simply a binary read. So in the end, in my practice, we do both.
Yeah, maybe I can ask question. No, sorry, John. Yeah, so because I think certainly it's good to have a follow-up amyloid scan for some of those patients receive that, but we never saw those patients come back because it's a reimbursement issue that they only come once to document it's amyloid positive eligible for the anti-amyloid treatment, but we never see them come back, for the, because of the reimbursement problem, I think, but hopefully.
I think, so my understanding is that's changed and that they are reimbursed serially, but you may not have seen them come back because we're just now on the cusp of 18 months, which is sort of that time frame when clinical trials were evaluating. So at our center, we're just now seeing the people starting to come back for amyloid PET, and we're actually getting the reason I asked about Centiloid is because we are getting a lot of requests for an amyloid PET with Centiloid for people who've been on anti-amyloid immunotherapy for about 18 months. But I see this as so for us, we have about 300 patients on therapy. So this is a big wave of PET scans coming in for us and for others.
So at my institution, we're not yet at the 18-month mark for our internal patients, but as I mentioned, I receive a lot of scans from outside. So I've had a handful of these follow-up cases. It seems like they are not being, a lot of the outside referrals are not waiting for the 18-month mark. So I've had a handful of them somewhere between 12 and 16 months. And then more recently, I had a really interesting case that was 7 months after the initial PET, and the indication was that the patient was considering switching from Leqembi over to Kinsula. And yes, that patient actually cleared their amyloid burden, which then begs the question, I'd be very curious to hear next clinical steps since their Centiloid score dropped to below 10 in those initial 6 months of therapy. And I will just add that of the patients that I've seen come in for follow-up, again, it's not a large N, probably 10 or so. Most of them have cleared amyloid successfully, but there was one case where the initial Centiloid value was around 105 and basically came back and it was hovering at that same value. So I've seen only one that seems like did not actually clear the amyloid at 12 months.
And I don't know, in primary care, I think the question is really who to refer for a PET scan. And I think risk factors play a role here because, maybe finding out somebody's risk by ApoE4 testing, ApoE testing, family history, those sorts of things. But also asking people, well, if you have a positive scan, would you want to go on one of the monoclonals? That would be my intent in describing the risks and benefits. And if they said no, then I think it creates a different sort of value of knowing equation of what is the value of knowing if the PET scan is positive, if it doesn't affect clinical care in one way or another. I had someone the other day who was about 60 years old with memory problems, and she just wanted to know if she had Alzheimer's. Her mother had it. And she wanted to know if she was having it. And I don't think it really changed her care, but it changed her outlook. And I think that, she was exercising and all this other, but we don't have the results of the scan yet, but I think it will have a big impact on her life actually to know. But so I think context of use is really critical in who we get the scans for. And in a neurology practice, it could be very clear that somebody's got some neuropsych testing done. The MRI shows bilateral hippocampal atrophy. There's a family history, and there's a good chance that somebody will have a positive scan that they have Alzheimer's disease. is worth doing if they're interested in going on the monoclonals. If there's not, I don't know really how it changes care. And it's really just the value to the patient of knowing whether or not they have it. And of course, a negative scan is very valuable. But then what do we do after that? Like a year from now or 5 years from now, do we repeat the scan again? And again, maybe blood tests will help us on that equation.
Maybe they should do FDG for that. No, because maybe different different type of dementia.
I was just about to add. I had a couple of cases where the amyloid was negative, and then they came in for an FDG. And I'd be curious to hear, what's happened in your practices. I know at some other institutions across the country, people have indicated that FDG seems to be phasing out and kind of replaced by amyloid. But at least in my experience, our FDG numbers are not going down, and what I see is the person gets an FDG first and then goes for an amyloid, and for a number of those amyloid first patients, then they come back for an FDG. And I kind of still think that FDG has a very valuable place in differential diagnosis given the frequency of co-pathology. But I'd love to hear your thoughts on that as well.
I think co-pathology is the standard of the day. We know 40% of people with Alzheimer's have alpha-synuclein Lewy bodies, and 40% of people with Lewy bodies and diagnosed with Lewy body dementia have Alzheimer's pathology. So I guess we're going to have a day where there'll be an alpha-synuclein PET ligand, and then we'll be able to image people based on their pathology, maybe TDP-43 as well, and tau. And then I wonder, what does that look like? Do people have to go in for 4 different PET scans on 4 different occasions, and they have a limited amount of exposure to radiation and all those things? How do we deal with the coming era of co-pathologies and comorbidities and combination therapy? I think that creates challenges where ultimately everything has to be validated either at autopsy or on PET scans. But I think the only way to address that is going to be somehow with validated blood tests in a way.
Yeah. And maybe some of, as the blood tests are coming through, so now amyloid blood tests are becoming more and more reliable. But with tau PET now being reimbursed, at least in some areas, perhaps we'll be seeing more cases where they're getting a blood test for amyloid, but then a tau PET for that next stage of confirmation.
Go ahead. Sorry, Howard.
So there are really good blood tests now for tau, but you don't get that regional distribution. You can't see the BRCA staging on a blood test, and that's kind of one of the problems I think with the blood tests will ultimately face. And the advantage there's a very clear advantage of PET scanning for the tangles because you see the regional distribution, which relates to BRCA staging and cognition, whereas the amyloid imaging really doesn't correlate with cognition very well.
Right.
Along those lines, because I think thinking about how amyloid PET and other PET tracers and potentially SPECT tracers like ioflupane are going to be used. Thoughts on specifically monitoring response to therapy with PET? What are your thoughts on being able to do that with plasma biomarkers? Because I hear that as an issue. Can you just assuming you're going to use amyloid markers to decide when to end therapy? What do people think about that?
I don't think we're there yet. I don't
Definitely
think we have
not.
Yeah.
Yeah. No. I think that's important to state out loud. I would not be comfortable using a blood test for a response today. Those clinical trials just aren't completed.
Yeah.
Right.
Which then I agree with that. And then that begs the question, is it acceptable to use the blood-based biomarkers for initiating treatment? Because if you don't have a centiloid score at baseline, what do you compare to when the patient comes from follow-up?
That's a good point.
Yeah, I think one of the unanswered questions is, is that how we decide when to stop therapy? I think that's also an open question. And is it, if someone had a positive blood test and a negative end or interim therapy amyloid PET scan, would you feel comfortable stopping someone based on that? But I do think that question of the role of amyloid biomarkers for deciding when to stop therapy is, we'll have more data in the next few years. But I think that's an area that's coming up now. We are having patients who were being asked to do follow-up and provide centiloids, as was discussed earlier. But I don't know that anyone really knows in a clinical setting what the right thing to do is.
Well,
I think
another-
it'll also be interesting to see how insurance companies handle ongoing treatment in follow-up as well. I know we've had some people who've had changes on the mini mental status examination, and private insurance has wanted to use that to deny ongoing therapy.
Hmm.
And so it'll be interesting to see if anything we report on amyloid PET scans then turns around into insurance companies taking away from the neurologist that decision and making payment decisions. No idea.
And in clinical research, we really haven't talked much about clinical research, but I think the blood tests and the brain scans have really transformed clinical research in this field. And I definitely think that the blood tests can play an important role in screening, large numbers of people to see who might be eligible for a clinical trial, and then confirming and the diagnosis with a PET scan would be in order, certainly. But that whole clinical research paradigm is changing dramatically now with the advent of these scans and the blood tests. We're even talking about spot blood tests where you can go out into the community and have a test on a piece of paper and do a spot blood test, which is really inexpensive, to see if somebody's got positive p-tau 217 or something like that, and then send those people for a scan to confirm the diagnosis of Alzheimer's disease. That's a big change in the costs of screening, which comprise half the costs of $400 million phase 3 trial. $200 million of that money, of that cost, is finding the patients. So being able to reduce those costs dramatically with a blood test, I think, is another important advance of how the blood tests and the scans work together to change the paradigm of research.
So yeah, I think if the panel doesn't mind, if we could shift gears a little bit and talk some about research and kind of the pipeline. Thoughts on how molecular imaging can play a role, as it has already and is an integral part of many trials. Any thoughts on kind of what's next or what should be focused on next? I think inflammation was brought up, which is a quite an interesting topic. Other targets relevant to therapies in development that people would like to discuss?
Sure. I think, as Howard pointed out, biomarkers are becoming an indispensable part of clinical trials to make sure that at initiation you actually have a target that you can treat, and then for monitoring treatment or response. So in addition to neuroinflammation, and I think primarily we're talking about TSPO PET tracers, there's a lot of talk also about assessing synaptic density. So the treatments for protection of synapses, and the group of agents I think most developed is the SV2A PET tracers. And then more recently, there's been a lot of focus on the gut-brain axis as well. I always like to put that in my home country of Croatia in Europe for early stage Alzheimer's disease and people with mild cognitive impairment due to Alzheimer's disease. Currently, the phase 3 trial that's available is actually testing semaglutide, so essentially Ozempic. So I think those are some of the targets that have been explored in recent years. And obviously, like was already mentioned, there's been a lot of progress with alpha-synuclein PET tracers. So differentiating people that have co-pathologies and making sure that the trial population is a clean cohort of AD only subjects, if that's the goal, I think is also relevant and important. To add to Howard's statistics, I think the statistics include that about 80% of people, especially in the elderly cohorts, have at least 2 co-pathologies, and 60% have 3 or more co-pathologies. So it's an immense amount of patients that have more than just Alzheimer's disease, which of course can then affect trial and treatment results.
Yeah, people with co-pathologies tend to progress more rapidly, especially if it's a mixed dementia with a vascular component. And we really don't have very good vascular imaging agents right now. And, it's the second most common cause of dementia is vascular. And, we have companies like Thorini that are looking at fibrin as a therapeutic to block the deposition of fibrin in small blood vessels. And because the fibrin binds amyloid so tightly and causes sort of mini plaque formation in the very small vessels of the subcortical regions. And so being able to image something like fibrin in the brain might be really useful in terms of identifying a vascular component. Right now, what you get, and we're still getting from radiologists, is on the MRI, there's subcortical white matter hyperintensities, and most of the time it comes back that it's normal for aging, when we know that it's not a good thing to have. So there's a big need, I think, in the vascular component of the disease.
For sure. And once the therapies went into effect, I started really paying attention to the degree of vascular burden and trying to quantify it, if with nothing else, at least the Fazekas score. But to your point, especially as I look at PET scans with prior MRIs, those are my two pet peeves: the vascular burden kind of normal for age, and the volume loss normal for age. And I think that's unacceptable, but it still happens, I think, across many institutions.
Yeah.
Yeah, I think what do people think about sort of composite multiparametric imaging? So sort of combine risk factors, composite risk factor from the various neuroimaging tests performed. I think that's something that's maybe not as innovative as a new PET tracer, which I think is also, I think there's a number of potential targets like those discussed here. But thoughts about that, in terms of trying to combine neuroimaging data, because right now I feel like it's very siloed.
Yeah, that's a great point, John, especially if you think about the blood tests. So, C2N has the Procivity AD test, and essentially that's what that's doing, right? It's not just the blood result, it's incorporating the age and the ApoE status, et cetera. And are there ways that imaging should be combining either across PET tracers or combining PET and MRI to give a better diagnosis or risk? I think there's a real opportunity there.
So to that effect, in terms of the imaging side, I'm a strong believer in hybrid imaging. And I think one thing to point out is, although not many institutions have actual PET MRI scanners, with post-processing software currently, it's very easy to fuse the PET with the pre-existing MRI, and you're actually able to bill for it as well. We're getting reimbursed at our hospitals at a rate of $400 per PET scan. So what we've instituted is that every time a patient gets scheduled for a brain PET, essentially a PET CT, there's a query to check if there's a prior MRI available on our RPACs. And if not, the patient is then asked if they had a prior MRI, and we have a whole system in place to actually retrieve prior MRIs from other institutions, so that by the time the patient arrives for the PET, the MRI brain is available on PACS. And then both the structural and the metabolic or molecular imaging information can be looked at side by side. And I think, they're very complementary to each other, and looking at the degree of vascular burden on the MRI or the microhemorrhages or the atrophy pattern can many times help you and aid you in, more accurately interpreting the PET scan as well, especially for FDG PET.
Agreed. Yeah. Other thoughts on sort of the pipeline, particularly how imaging in the future or with ongoing trials could play a greater role? I think the things discussed already are on point, but other thoughts?
Yeah, I think we should, hopefully the tau will be more available to do that, because I think in one of the trials from Lily, that tau played a crucial role for the patient selection. I think not just amyloid positive, you need to make sure that the patient has just enough tau, the certain disease, but not too severe, so it has a sweet spot that certainly those will be the patient most benefit from the anti-amyloid treatment, I think. But certainly, there's also some pipeline for anti-tau treatment, and also I think the tau shouldn't be underlooked. So we should try to advocate that this should be more available and then more reimbursable. Yeah, so that could help a lot in terms of not just the clinical trial, but also in the actual treating actual patient. So you certainly don't want treat the patient with amyloid but no tau. Certainly I think probably not going to be very helpful. Yeah.
Yeah,
I just want to.
go ahead.
Sorry.
Go ahead, Tammy. I'm sorry.
No, I was just saying, I want to echo a little about what you're saying here, and what John and Howard have said earlier, and that just because we have amyloid and tau doesn't mean we have all the answers, and these patients are really complex. There's a huge opportunity for new molecular imaging agents to be developed, to be validated, to be tested. And really not that many people with expertise in doing that coming through the pipeline. So for the people on this call, if you're a trainee or if you're a mentor to trainees or people who are interested, I think this is a fantastic field for people to be working in. And there's definitely, I know of at least 3 different T32s in this space that are having trouble filling positions for postdocs, which is crazy because we definitely need scientists and clinician scientists to be working actively on this, and would love to see more people getting involved.
One of the challenges we face is we often get requests and applications for in drug development, this phase 0 studies. And since there are an infinite number of targets and small molecules and so on that could be developed for the disease, if we started funding phase radio labeling of each of these molecules and putting them through the phase 0 process so that developers could show there's target engagement in the brain, we would be funding a whole slew of novel neuroimaging agents with relatively potentially limited application because not everybody's going to have all the different problems, and not just from a symptomatic biological point of view, but from an actual target engagement point of view, to show that the drugs actually are binding to their targets in the human brain. So we don't know, should we be funding alpha-synuclein imaging agents that would have wide application, or somebody who's got, NRX0023, and they want to make an imaging agent out of it to show that, it's going to work. And I think that's an underutilization of PET scanning, even though it might have ultimately limited clinical application. The role in drug development is very important.
Yeah, I think a lot of the very promising the new tracer or new target, I think it is being either in the preclinical or in the first in human study. But certainly it's very difficult to translate to actual a clinical available tracer. I mean there's in terms of the neural information, I think certainly there's TSPO has been available for decades. I mean, and then even the most recent SV2A, I think I'm lucky to be involved in one of the first site we published that, but certainly I think there's still a long way to go, before any of those tracers be available in the clinical setting. So I think we really need some, if you don't get the support from the big pharma or something, this won't fly any longer. I think it's probably still going to be research, probably not going to even being used as a clinical trial, imaging marker. Yeah.
I'll just add that TDP-43 agent is on top of my wish list, and it seems like that's not going to happen anytime soon. But that's on my wish list, and I wanted to kind of just circle back to tau PET, which is slowly emerging in clinical practice, and highlight Minkai's point that patients on Kinsula clearly did better when they were in early stage disease with lower tau burden. So that's a potential use of tau PETs today. And then the other side of the coin is that now that we've had a handful of these cases in clinical practice, we're seeing non-AD patterns of tau uptake as well. So I've had a couple of patients that were amyloid negative and had tau accumulation. So I do think tau may have a role in differential diagnosis and assist us in diagnosing other tauopathies as well. Yeah, so I'm very excited to see what happens in the next couple of years in that end.
I think that's really important, Anna, because we really can't make a diagnosis of PSP very well and the other tauopathies. And you have the problem of the tau 3R and the 4R, and some of these agents see both, and some of them only see the 3, but then you can't see the 4 on the I think that's a really important area of future development.
Yeah, I can tell you, it's very exciting that a PI 2620, one of the second generation tau agents, currently has orphan drug status with the FDA for both PSP and CBD. Although I can tell you at the same time, from my personal experience with the agent, I have a small study looking at patients with primary progressive aphasia, and none of the non-fluent or agrammatic PPA cases, so those that also presumably have 4R tau pathology, all of them are negative. So I think there's still a lot of work to be done with actually more accurately imaging the other isoforms of tau.
Right.
And that's of all the other agents that we've discussed that are still in development and used in the research setting, probably tau is the one that is of all of them really on the precipice of actual clinical relevance and clinical use in daily practice.
Yeah, we're invested in a company called Apranoia that has a tau imaging program like that with an agent that I think it binds both 3R and 4R and something like that. But yeah, there's a lot of development needs for those kind of agents.
For sure.
In the setting of Alzheimer's disease, do we think, the approved and late phase tau tracers are sensitive enough for lower levels of tau? And how important is that if we're missing kind of earlier stages of tauopathy?
My experience is that they're quite sensitive. So, MK6240 has, in my experience, the best dynamic range at low levels. But to be honest with you, in our publications at the night ADRC, people that are amyloid positive, but very carefully, clinically phenotyped as CDR0, we're still able to pick up tau PET positivity with fluortaucipir. And in particular, we've been doing a lot more work now looking at, instead of a straight SUVR with a set of regions, looking more at occupancy, so percent of the voxels in the brain that are abnormal. And that's giving us even better sensitivity to early disease progression, and might be, we're trying to incorporate that into our thinking about clinical trials going forward.
Yeah, I realized that the FDA approval of fluortaucipir was based off of its ability to really detect more advanced Braak stages. But similarly, I'm not so as confident to speak about it yet, but at least as far as my clinical experience, it seems like it's quite sensitive in detecting earlier stage disease. And again, other tauopathies as well, much more than I would have guessed from what's currently available in the literature and how it's been publicized, again, as only successful in identifying more advanced Braak stages.
Well, great. So I think kind of moving on to another topic that I'd like to discuss is kind of collaboration, advocacy, kind of steps forward. And for professional organizations like the SNMMI, what should we be doing that we're not already doing to better support Alzheimer's research? I think Tammy's point about a training pipeline for scientists and clinicians is key. I think that's one area. We could discuss that more, but what should professional societies and scientific organizations be doing?
I think the SNMI has been pretty dedicated, at least from our Brain Imaging Council, we were trying to advocate that, the importance of brain imaging, and also we work together with the Alzheimer's Association, I think, to publish the appropriate use criteria. But also, I think SNMI also been funding some of the research grant and for the training, for those, I think. For some of the pilot study, and then I think in terms of the education, I think we trying to organize a specialized training program. I think some of those the readers training I think is already being sponsored by the vendor, but certainly I think we also trying to incorporate those in our either midwinter meeting or annual meeting, and then we provide a serious CME program as well, to do that. And then I think SNMI also trying to advocate and then trying to help, for some of the reimbursement or accessibility for this very useful imaging marker. And then I think yeah, and I think of course, Alzheimer's Association, has already have the big, like data sharing, ADNI, some of those, big data, I think can foster the research progression. I think, but all the academic association should work together, trying to help, to make, to work, to attack this terrible disease. Yeah.
And I think, to just highlight what Min-Kai was saying about education, we've been trying to recruit dedicated brain PET readers to kind of meet the growing demand over the last 2 or 3 years without success. So I think across the country, there is a relative shortage of people who are comfortable with kind of interpreting brain PET, and that goes for both nuclear medicine physicians and potential neuroradiologists that have additional training. So I think focusing on recruiting talented trainees and engaging them and highlighting that this is really an exciting time to be in molecular neuroimaging is very important, because I think, and from speaking to other colleagues, we're certainly not the only institution struggling to hire additional radiologists that are comfortable and skilled in interpreting these studies. And to Min-Kai's point, as part of the FDA label, all the amyloid radiopharmaceuticals do have reader training programs, but then going back to FDG PET, there is really relatively sparse opportunities to educate yourself aside from reading review articles and attending lectures at conferences. So I think as a whole, as a community, we really need to invest in kind of training the next generation of brain PET readers.
Yeah, I'm going to add that maybe, some of the research with the AI or some of the machine learning, they probably could do a very decent job, you could, incorporate those in some of the software like MIM or something, that could also give us, build up some of the reader, some confidence that, then, I think, you just need, even neuroradiology, they need a certain case of the nuclear medicine imaging training, in order to feel comfortable to read those. But eventually, I think, people start to recognize the importance of that. I mean, people want to spend more time to train themselves. I mean, this certainly, eventually, I think we'll get there. But depending on how long it will take. Yeah. I don't know about Jonathan or Tammy. Yeah.
Yeah, I was going to say one of the things I've seen, John, as we've watched, so this rollout for dementia care hit neuroradiology, I think, before it hit nuclear medicine, partly just because the amyloid PET scans weren't reimbursed until 2024. But Anna and I have been part of this rollout on the American Society for Neuroradiology side, and then more recently with the ACR as well, American College of Radiology, because what I've come to learn is that the constraints and practice demands that our colleagues in private practice and in community settings and in like hybrid academic settings, where most of the patients in the US are getting their care, the challenges they face, those nuclear medicine physicians and radiologists, are with the demand for volume and complexity of cases, very, very, very demanding. And finding ways to make sure that they're getting education about this disease. And it's more complicated than just a positive or a negative scan, right? We've talked about the overlay of centiloid. We've talked about the need to understand typical and atypical patterns that you might see on that tau PET scan. Finding ways to meet that group of physicians and to understand, where they are and how to get them this information. It's a challenge we're facing right now. And I would say my guess is that SNMMI is a lot like ASNR, that it's a lot of us in academic practices where we have the luxury of being able to attend and participate in webinars and go to tumor boards and dementia boards and dialogues. But how to, in order to meet the demands for care for the U.S. population, we need to reach out to those physicians practicing in these other areas as well.
Yeah, I was going to say outreach to the community beyond, the people actively involved in society is key. Agreed. Howard, do you have any thoughts on, how SMMI and other professional organizations could facilitate, amyloid care and research, things different than what we're doing now?
Well, the way I understand it, there are large parts of the country that have no access to cyclotrons. And that's a rate limiting factor in the utilization of this new technology. I don't know if SNMI can do something about that, but you can have the smartest guy in the room that can read these things, but if you can't even do them, then that's a roadblock.
Yeah, to
Yeah.
Howard's point, I think the estimate is that about 5 to 10% of the U.S. population is without access. Considering that you need a cyclotron in at least a 200-mile radius of the PET scanner, and looking at the overall distribution of PET scanners in the U.S., that the total number of scanners is about 2,500. So that's another significant handicap that we haven't discussed yet, for sure.
So I guess,
sorry to interrupt you, John, but I guess to that effect, I would love to know, especially Min-Kai, but the rest of the panelists as well, what they think about the potential for brain-only PET scanners, and do they think that they might be able to meet some of that demand? I think Min-Kai has more experience than the rest of us, so I'd love to hear everyone's thoughts on that as well.
It depends on what kind of demand. I mean, certainly, we have several brand dedicated PET scanner, but they come for either the most highest sensitivity or resolution, but those are probably not necessary for the amyloid, or not for tau, for FDG. But certainly, I think some of those, that's probably more for research. But certainly, I would say probably some of those, like portable brain scanner. I think those, I think there's been quite a few, available from, and so from the other vendor that those could be useful. I mean, if you considering you have a very busy oncology clinic, and you want to add another pipeline for the brain, just for brain, you could just need a small room, just or even a portable scan. They could go to the patients, after injection, you can bring the scanner to the room, to scan those. I think that could be quite convenient. Yeah, and you don't need a very high resolution or something. You just need a good enough imaging quality to do those.
Yeah, so one of those that you're referencing, FDA-approved brain-only scanners, is only about $500K, and there are people that are thinking about its the ability of housing that kind of scanner in a neurology clinic with an infusion center, and kind of enabling convenient access to care. But again, I think that's still under development for now.
Yeah, I think the tracer availability is probably more important. If you have a scanner without tracer, that probably will be problem. Even the center like us, sometimes because the demand for amyloid tracer is so high, so we've been shopping with 3 different trace vendors. Just sometimes, it's always short of, not quite available. So I think patient has to wait a few days or sometimes a week or 2, to get this tracer available. Yeah, but I think because that's probably the high demand nationwide, there's some problem we face, but certainly we're probably more lucky to have all the tracer available in the pipeline. Yeah.
To your point, we used to work with only 2 of the 3 vendors because we thought that was more than enough, and actually more recently we're contracting with the 3rd vendor as well, just to have that certainty that we will have reliable access to radio.
That's the key, because we certainly don't want to reschedule patient study because one vendor or the other 2 vendor cannot provide the tracer. Yeah, then that brings to the importance of the Centraloid. That since you're scanning all 3 different tracer, you certainly need to standardize your quantification. That certainly is very helpful to have those available of Centraloid scale.
Yeah, and I think you bring up an interesting point about, either less expensive, more easily placed PET scanners, or also the possibility of mobile PET units, going to communities. Because unlike some of the cancer studies we do, while these are really important studies, they don't have the same urgency, So if you get referred and it's a month, it may not be that big a deal if you're waiting for a scanner to come to you. For the brain only, I think it's an exciting technology. I think the question is, especially with so much growth in oncology, is that going to serve the institution's needs? But they are a lot cheaper, and so I think if you could fill it, or at least keep it fairly busy, it is a viable alternative.
Yeah.
John, I know we're running out of time. I'm just posting in the chat. I don't know if the readers can see it, the viewers can see it, the link to this announcement about this consensus statement we've been talking about throughout the conversation. And I did just see someone had a question in the chat about what is the Centiloid? So I wonder maybe if Minkai or Anna or John, if you wanted to address that quickly for them.
And
Sure.
Anna, do you want to take a chance or take a shot at it?
Let me give it a try. So the Centiloid, no pressure in the last minute. So the Centiloid scale it was developed really as a research tool to enable researchers to compare amyloid PET scans done at different institutions with different tracers, different protocols, and different scanners. And the idea is that it's an unbounded scale with two anchor points, 0 and 100, with 0 being the mean gray matter amount of amyloid on a PET scan in a normal, young, healthy individual, and 100 being the number in a patient with moderately advanced AD dementia. So typically some cutoffs that are helpful to keep in mind is that a Centiloid value of less than 10 effectively excludes Alzheimer's disease. It means that on comparison to neuropathology, amyloid plaques are absent. Centiloid score of 20 and up means that there is at least moderate amyloid plaque burden in the brain parenchyma, and a score of 50 and up has the best correlation with an AD diagnosis at autopsy. So the relevance of the Centiloid scale, aside from its ability to be used to compare scans of different radio tracers and different protocols, is that it was used as the key entry criterion for the anti-amyloid monoclonal antibodies that are currently on the market. And it was also used to assess treatment response with these therapies as well. And as we mentioned earlier in the talk, currently there are 2 FDA-approved clinical workflows for Centiloid evaluation, so for Centiloid post-processing of the amyloid PET scans that are being done, and those are provided by MIM Neuro and then Siemens Singo as well.
Thank you. I think that's an excellent explanation. And
just to add, sorry, to the group, that if anyone is further interested in knowing about amyloid PET quantification in clinical practice, I'll put it in the chat. There's an excellent review article by Pemberton in the European Journal of Nuclear Medicine and Molecular Imaging for 2022 that I highly recommend.
Well, I'd like to thank everyone who attended this webinar, as well as our speakers. It was a really great session. I think we could probably go another hour, but our time is up. So thanks to all of you for giving your time and participating. And it's an exciting time. Look forward to future discussions.
Bye-bye.
Thank you so much.
Bye-bye.
Bye-bye.
Bye-bye.